Good afternoon, everyone. First of all, I would like to thank the organizers for inviting me to discuss today about whether or not liquid biopsy should be employed in metastatic breast cancer in 2020. Now, my first point today has to be what biomarkers are we looking at in liquid biopsy. So I dug up a bit all biomarkers that are relevant in metastatic breast cancer, and I classified them, or I grouped them in specific alterations in the genome. Now we first have, or I will discuss about point mutations or SNPs. Then we will briefly go through copy number alterations, genomic scar testing that is now increasingly relevant in the field, and gene expression-based classifications. So this is a bit of a summary of all the genomic-based biomarkers that I think are of interest and would be of interest to have in a liquid biopsy test. And I ordered them based on how simple or how available they are for them being tested in the plasma setting. So we will start with those that are simpler to profile in liquid biopsy and end up with those that are more complex to obtain from plasma. Now, the first critical requirement that we have to have in mind when thinking of implementing liquid biopsy is whether or not patients are shedding ctDNA. You know that ctDNA shedding consists of fragments of DNA derived from the tumor that arrive in peripheral blood and can be isolated in plasma and further analyzed from there. Now, we know that ctDNA shedding is not equivalent in all the stages of cancer, and is not equivalent either depending on the tumor type of origin. We now know, based on several works, that around 90% of patients with metastatic breast cancer are shedding ctDNA into the bloodstream, which means for me this could be potentially a good scenario. There are other tumor types with even higher shedding patients, such as colorectal cancer, but I think metastatic breast cancer should be, based on this data, should be good enough for us to think of this as a potential test for all patients. Now, for point mutations, I listed here some of the genes that are of interest. These are all oncogenes. And the first thing that is relevant when analyzing mutations in plasma is the fraction that derives from tumor. Now, in metastatic breast cancer, the median mutant allele fraction of clonal mutations, which means those mutations that are present in all tumor cells, is 4%, which means that this fraction is going to be small. In general, it's going to tend to be below 5%. 5% is the sensitivity, or the normal sensitivity of NGS. So I listed this here because later on I will go into NGS. And due to these observations, this kind of observations in the field, what we first went for was for high sensitivity techniques such as digital PCR, and as well as qPCR based kind of testing. Now, if the median MAF of the clonal mutation is around 4%, the remaining mutations that can be detected in plasma is going to be much lower. And I obtained this slide thanks to this is data from Gardan, where they provide the number of mutations that are detected at all the different mutant allele fractions. You can see here that the median of mutations detected in liquid biopsy is in fact 0.4%. So it's 1/10 of the value of clonal mutations. So since most mutations are going to be subclonal, they will be below this 4%. And this is what you're seeing here. The sensitivity in our test has to be very high. Now, since we started working on oncogenes, such as PI3K, such as estrogen receptors, such as HER2, we started working with these extremely sensitive PCR-based tests, which are these one assay per mutation kind of tests. And these work very nicely for oncogenes. And this is exactly what happened with the testing for PI3K. This is the data coming out from the PI3K mutations and alpelisib. You know this much better than I do. But there was a local assessment of tissue and versus plasma, and a calculation of the PFS depending on whether the mutation status was taken from tissue or plasma. And you can see here that the results are equivalent, are very similar, if not a bit better with plasma. So this came up, or this was the reason why it is now accepted that PI3K status may be extracted from plasma samples. And if we were only going to discuss what is in the guidelines, I should stop my talk here. But I will go, I will go ahead and discuss all other potential biomarkers. So you can see here, PI3K was, in fact, here, it was tested with a qPCR-based test. But the problematic with this is, oops, sorry. The problematic with this is that we cannot achieve, sorry. We cannot achieve profiling of a lot of different genes or a lot of different positions in the genome if we are using these kind of tests. So if we were to look for PI3K estrogen receptor plus ERBB2, we could not go via this kind of tests because we would need huge amounts of plasma to perform all the testing. So we need to go for NGS. Not only for these genes, but also for the tumor suppressors such as BRCA1 and 2. So what has the community done with respect to this? There has been chemical improvement. So you now know that 5%, around 5% is the sensitivity of NGS. There have been chemical improvements using unique molecular identifier kind of chemistry. So we are tagging all the molecules that are present in plasma, and afterwards we are deconvoluting this information. And we have also, there has also been an improvement in the bioinformatics pipelines that are able to remove background noise. So all of this setup has enabled liquid biopsy tests that are that we can already acquire or we can already order, has placed sensitivity in a place where we can start working and detecting most of the mutations that are present in plasma. Now, one of the conditions to this, to performing this kind of analysis, is that we have to go to very high sequencing depth. This will sound empty to you, but or maybe sound empty to you, but the consequence of this, the direct consequence of this, is that these tests are expensive in sequencing. Now, when we move on to other kind of biomarkers, this is going to be important because this is going to be hampering enlarging our panels. So our panels have to be kept small or small enough that we can pay this requirement of very high sequencing depth. Now, something that has also been reported, and I think we have to bear this in mind, is that these platforms that are able to initially perform with extreme sensitivity in NGS have also been shown to have a high degree of discrepancy between them and deliver some false positive codes. And you can see here that below 1% mutant allele fraction, we start seeing some of these platforms, some of these vendors providing some non-true or completely true codes. So this is something to bear in mind, and this is something where vendors will find a place to improve in their performance. Now, the BRCA1 and 2 mutations, this is a very interesting biomarker. Germline BRCA1-2 mutations have an approved line of therapy in metastatic breast cancer. And this is around, the prevalence of these mutations is around 7% if we add up germline and somatic events. Most of the germlines are located in the triple negative subgroup of breast cancer. And you might be thinking here, all right, I don't need a liquid biopsy test in order to define or in order to identify germline or somatic BRCA1-2 in my patient. And this is true. But what has been described, and it was originally described for ovarian cancer, is that these patients that harbor, in particular, those harboring germline BRCA mutations, are reversing these mutations and becoming resistant or refractory to PARP inhibition. Now, this has also been observed in breast cancer. And you can see this study here where they observed reversion mutations, in particular in those germline BRCA mutant patients that have been receiving PARP inhibitors. The fact that this is tested in liquid biopsy and not in local biopsies is that liquid biopsy is able to show us many different reversion mechanisms, many different reversion mutations that are in fact arising in different locations. This is a convergent evolution kind of a thing driven by PARP inhibition, whereby we can see all the complexity and we can evaluate what is going on in our patient, how the alleles are evolving throughout time, and how many of them we have. So this we have to study in liquid biopsy. We don't have many other options. We're not going to biopsy every single lesion of the patient. So if we want to follow up what is going on in these patients, we need to use liquid biopsy testing. And this is a very nice example of monitoring in breast cancer, I would say. So, oops, sorry. So the next biomarker is copy number, and this is going to be a bit tougher to test in liquid biopsy than point mutations. It is accepted, or the way to go for copy number detection in liquid biopsy is accepted to be shallow whole genome sequencing. So we sequence the whole genome at very low coverage. This looks like it's going to be very expensive because it's whole genome sequencing, but in fact it's a very low coverage depth, so it's not that expensive. Everyone can do it. Here are some data just to show you. This from a patient coming out of my lab, where you can see how copy number behaves in tumor versus matched plasma of a patient. You can see the alterations are detected very nicely in plasma versus in tumor. So this is, I would say, a reliable, and this is a nice testing method. What is the problem here? What is the caveat here? The thing is that this is subject to the dilution that we observe in liquid biopsy. So if in this case, this patient had a lot of tumor fraction, it was around 40%. So in that pie chart, you would have a 40% of red coming from ctDNA. When this goes smaller, when this decreases, we start having issues with calling copy number from liquid biopsy. And what you might detect or you might observe or might happen to you is that patients have an amplification in HER2, for instance. If they have a low tumor fraction in their plasma, you could come up with a result of non-amplification in this plasma sample. All right, so this is the main limitation of copy number. And it is difficult to come to change this, or this is difficult to manage technically. And this is a risk. If you have a low tumor fraction and you don't see an amplification that should be there, please recheck it or go and biopsy your patient. As for genomic scar testing, I think this is a very interesting kind of biomarkers, and these biomarkers are going to suffer from a different kind of issue, but they are increasingly interesting, and I wanted to discuss them here today. These applications are not mainstream, so if you want to go and order this kind of testing in liquid biopsy, this is not going to be something you can find easily. The reason is that they both involve this kind of markers involve huge regions of the genome that have to be sequenced. So if we have a lot of regions and we have to go very in depth of all these regions, this starts to become a very expensive test. So HRD, you know what HRD is. Basically, cells that are unable to correctly resolve double-strand breaks because they, for instance, have a mutation in the BRCA genes. They have to go via different alternative repair mechanisms that are already present in the cell, but that are not the ideal mechanism of repair. So these alternatives mechanisms, once they get activated and finally the cell succeeds and is able to divide, they fix they fix some scars in the genome, and they are mainly two. They are gonna be LOH, loss of heterozygosity, in a large part of the genome, if this was the pathway that was activated, or they are gonna leave behind small deletions in microhomology regions if we have these other non-homologous enjoining repair activation. So depending on what the cell decided to go for, we will see different scars in the tumor DNA. And the first one I mentioned is LOH, and LOH is very well known and very heard of. And what basically we are talking about is that with LOH, we are losing one of the two parental alleles. And this can happen in a particular position in the genome, or it can happen in larger genome regions in the chromosomes. When we have an HRD situation and the cell has to repair using one of these alternative modes of non-ideal homologous recombination, the cell ends up losing one of the parental alleles. Well, I will not go into all the details, but you can see there are large portions in the genome that suffer from LOH. And I will not discuss this into a lot of detail, but this is the normal scenario, and this is an LOH, where this line becomes 2. That is an LOH. So depending on the number of regions that are suffering LOH, and depending on how they are, but we will simplify this. We are able to calculate number of regions that are suffering LOH, and hence probabilities that the higher the number of these regions are, higher the chances are that tumor has an HRD issue. Now, these kind of tests have to be genome-wide, because we have to look at all the chromosomes in the genome, and those are at least 20 megabases, which means this is more than 1,000-fold of what a regular small liquid biopsy panel is. So basically, including this kind of scores in liquid biopsy will make the test much more expensive. Plus, we are going to have also the issue that this allelic imbalance is tougher and tougher to detect when our ctDNA amounts are small. So this is going to happen. This will appear in liquid biopsy tests, but it will take a while. The next kind of biomarker, which are DNA mutational signatures, those were derived from TCGA, basically from TCGA data, where they came up to realize that not only the number of mutations per genome, tumor genomes, but also that these mutations in each of these tumors had particular characteristics, or they could group mutations by different contexts. and generate different signatures. There are signatures for MSI. There are also signatures for BRCA. Sorry, for BRCA. Oops. Sorry, I'm struggling. Okay. So there are also signatures associated with BRCA. Now, when we're looking at the TCGA kind of BRCA mutational signature, in fact, we are looking more into, we are not looking at LOH, we are looking into non-homologous joining activity, which has a scar or comes up with a scar of a longer kind of deletions in microhomology regions. It doesn't matter for you, but I just wanted to highlight that when we look at BRCA, or we are speaking about BRCA mutational signature in an NGS test, we are not talking about the HRD LOH score. It's a different kind of scar. We are looking at the same thing in the end, but it's a different phenotype. It's a different symptom for the same illness, okay? But there are two symptoms, so to speak. In this case, the situation is even worse because this happens not so many times in every genome. So in order to obtain these BRCA signatures, people work with whole exome sequencing kind of data. So this is going to be an issue. This really is going to be a bit more complex to implement. I ordered them by complexity. The next mutational signature that can be an issue also is the APOVEC. This is very interesting in metastatic breast cancer, and increasingly so. There are some mutations typical of metastatic breast cancer that are produced by APOVEC activity. This has a particular signature, and this could be relatively simple to detect in those tumors that have high TMB as a result of APOVEC activity or other kinds of mutational scarring. But it's going to be complex if our genomes have low TMB, because detecting all these passenger mutations produced by APOVEC activity is going to be complex. So this other kind of biomarker is going to also come a bit behind. And finally, gene expression-based classification. I listed this biomarker because I think it's relevant to the tumor type, but this application is so far not available because there is no, or at least has been no successful circulating free RNA endeavors, including exosome analysis, including different kind of approaches. We are not able to obtain RNA that we can analyze and based on that come up with the classification of metastatic breast cancer. So this biomarker is the most tough one because basically this is still not there. So if that is of interest to you, you have to wait a bit longer. So in favor of liquid biopsy, of implementing liquid biopsy, of course, for patients, more convenient, non-invasive. For clinicians, it's also more convenient and non-invasive. You can monitor your patients. And sometimes biomarker detection, such as the BRCA germline reversion mutations, is superior than tissue. For the labs, sample, at least quality of samples are better than FFPE. But the limitations are still there. There are no reimbursement policies. Liquid biopsy is not present in all the guidelines. So there is a confidence building stage here going on, also in parallel with clinicians, I would say. And for the labs, well, we have to deal with these low concentration samples, extreme diluted mutant alleles in some occasions, techniques that are difficult to implement, and in routine labs, I would say even more, and some biomarkers that are not readily available yet. So in conclusion, no, in order to answer the question of my title, what I would recommend in 2020, I would say yes for PI3K, for sure. And in selected cases, cases that are difficult to biopsy, cases that you are seeing a progression disease that you want to see, you want to monitor, and you want to see what is going on with that patient, for sure I would go for that. And then, well, in 2 to 3 years, maybe we could have again this discussion and see where we are at with the other biomarkers. So yeah, thank you very much, and take it easy.
Thank you so much, Anna, from this brilliant talk. Very, very clear. I think with very clear points and things to be aware of. And just to follow, the title, from your point of view, Anna, which is the next biomarker beyond PA3K mutations that will be ready to be used in clinical practice?
Wow. That is a good question. Well, beyond PA3K and beyond ERBB2, no, let's say.
ESR1 may, or so
I mean,
you think
ESR1, yeah, ESR1. ESR1 is a very nice biomarker. I think if we achieve some signal from the clinics, that could be a nice biomarker to have in the clinics. But maybe since we are talking a lot about BRCA, germline, etc., kind of variants, HRD or LOH scores, I think those could come also soon. This kind of LOH scorings and trying to identify these potentially HRD kind of tumors in order to enrich for better candidates for PARP inhibition.
So do you think that at the end, plasma-based DNA-seq will replace germinal testing as a gold standard for BRCA mutation?
Well, I think for germline analysis, we will still have to rely on a final call provided by somebody performing the test on normal tissue or whole blood or whatever. But I think the liquid biopsy test will come prior to that happening. So you will have a liquid biopsy test telling you there is a suspicion of a germline variant, and then you will ask your germline specialist to perform the test that is able to tell you that this is of germline origin. So I think we will shift and we'll have first liquid biopsy, and then we'll have whole blood testing for germline determination.
Okay, and how about ApoBec? Is it a dynamic also signature? What do you think?
Yes, I think ApoBec is very interesting, and what we are seeing, or what is being said in the literature, is that there are waves of ApoBec activity in the tumors, and we are seeing some patients for which we can detect older waves of ApoBec activity, and then newer waves of ApoBec activity. So this is a dynamic thing going on. We still don't understand how this is happening, how this is regulated. We don't know how to explain that, but we are seeing patients for which ApoBec is getting activated during metastatic disease. So this is definitely going to be something we are going to be looking at.
That's great. Thank you so much, Anna. I don't know, Mafalda, if you have any other questions?
I think we had a great discussion on circulating tumor DNA, and I'm really glad we work at the same institution. So we will keep on discussing these, and hopefully also with all the SALTI group, and try to get these things into the clinic, right? So that we can benefit all our patients. So, well, thank you so much for all your assistance on this UpToDate virtual summit. We had 4 great talks, and we reviewed almost all the metastatic breast cancer treatment landscape, and also a great tool that will boost research in metastatic breast cancer, that is liquid biopsy.